So those who have got no PowerPoint presentation, what they will do, they will present their poster here. We will discuss in the same manner as the PowerPoint presentation. So all of you please kindly ready and get ready for 3 minutes presentation and 2 minutes discussion. Okay?
2 minutes, 1 minute discussion, sir. 1 minute.
1 minute, sorry, 1 minute discussion. It is 4 minutes total game. So please come. So first contestant is S. Das, I think.
Yes, yes, das.
S. Das is the first contestant. Please come. Please present. S. Das क्या है? Topic क्या है?
On female virus shortening and data osteotomy in DBH.
अच्छा अच्छा.
Good morning, Chairman sir, Co-Chairman sir, and friends. My poster was open reduction femoral Bharat derotation shortening osteotomy with DEGA.
Below 5 years. I am going to present my early results. Purpose study is to report our experience of last 8 years by evaluating the clinical radiological outcomes of combined approach in developmental dislocation of hip below 5 years. All the papers has been described. They describe that early open reduction gives us the best results. Our protocol is identify the case as early as possible, give them public harness. Once instability is detected, by then patient is taken to operation theatre, then arthrography, adductor tenotomy or spica. If still there is instability, then we go for open reduction. So we have managed 42 hips, out of the 8 hips we have managed conservatively, 34 hips we have operated by the open reduction method. So these are the surgical steps of the methods. And clinical excellent stable painless limp negative trend limb and full range of motion, that is excellent result in Barrett et al. Described 1986 28 cases. Radiological Severin classification excellent results in 30 cases, and avascular necrosis found in 1 case. So these are one case, unilateral case which has been undergone open reduction method, and you can see the movements. And this is also another case, open reduction has been done. This the cross leg sitting and squatting possible, bilateral case which has been operated, and results is good. So to conclude, open reduction recommended mostly after working age. Anterior approach is always recommended. Acetabular clearance and division of transverse acetabular ligament allows stable concentric reduction. Taut capsuloplasty and femoral shortening varus derotation shortening osteotomy recommended after tight reduction. DEGA osteotomy improves the shape of the acetabulum, and long follow-up results are also good. Thank you very much.
In time. Acha, Das, Dr. Das, you have presented in time.
Sir.
So, what is the difference between the plain Weiss osteotomy and the DEGA osteotomy? And how do you determine the antiversion?
Antiversion is pre-operatively, antiversion is assessed by the method described, clinical method. In the operation theatre also, during the reduction process, we reduce it. After the osteotomy, we proximal fragment is internal rotated, and stability is checked, and then distal fragment is derotated and fixed. So in that way, we assess the antiversion in the operation theatre during many operatively.
Thank you. Any question?
What are the complications with the DEGA osteotomy?
Complication operatively, we may go towards the acetabulum, we may damage the premature acetabulum, so that there will be problem in operatively. Suppose by any means we during the surgical procedure not properly identify the margin, if we damage the superior part of the acetabulum, there will be growth arrest and acetabular dysplasia will be maybe more. So you have to proper level has to be selected, and osteotomy has to be done, graft has to be put on the superior side, lateral side, proper graft, so that the this osteotomy will be down and the head will be reduced position.
Will it be better to go for Pemberton osteotomy in these cases than DEGA?
DEGA osteotomy is easy to learn, easy, and Pemberton osteotomy, DEGA osteotomy will be good.
Okay. Any more questions? Thank you.
Thank you.
Thank you, sir.
Thank you, Dr. Das.
Thank you, sir.
We'll call upon the number 7, that is Sobti. His name is A. Sopti.
Yes, sir.
Is here?
Yeah.
You have got your presentation
Yes, sir.
loaded? Please present. 3 minutes plus 1. Give your marks.
The copy of
So that,
my post office, small copy of my post office.
we'll have a discussion of that. So you don't have a presentation,
I
isn't
have a
it?
presentation also.
Huh?
I have a presentation also.
Also,
Yes.
very good.
Good morning, respected chairpersons and colleagues. My topic for the day is progression of osteoarthritis in the untreated compartments, a comparison between HTO and UKA. The HTO and UK are established treatments of treatment for medial compartment OA. However, there are concerns of OA progressing in these untreated compartments, which may lead to failure. Thus, the purpose of this comparative retrospective study was to examine and compare the shift of radiological parameters that represent the patellofemoral joint and HTO after UKA. To examine the effects of OA progression of the untreated compartments, and also to note the correlation of the latest follow-up of patellofemoral pain and functional scores. The patients included were 42 knees with HTO and 59 with UKA. These are the demographic values. The criteria for inclusion are as follows, which are standard as in described in normal textbooks, and the exclusion criteria particularly was range of motion less than 100 degrees, flexion contracture of 15 degrees or more, LCL laxity of grade 3 or more, previous fractures, operations, infection and rheumatoid arthritis. The patients were assessed at 1, 3, 6 and 12 months thereafter with a radiographic examination of the knee AP joint, knee joint AP lateral Merchant's view scanogram. The preoperative and latest follow-up radiographs were evaluated for measurement of the patellofemoral indices. The results showed that there was statistical significance in change of the patellar indices from the preoperative to postoperative, as well as the preoperative and latest follow-up osteoarthritis grade of lateral tibiofemoral, medial patellofemoral and the lateral medial patellofemoral compartments in the UK and HTO are as follows. To summarize, the most important findings of our study was there was OA progression observed in all the untreated compartments with both the procedures. Although in comparing the amount of postoperative OA progression, there wasn't any statistical significant difference observed between the two groups. However, within the groups, even though there was some progression of OA seen in the untreated compartments only, the knees with UKA showed a statistically significant progression of the OA grade from the preoperative state to the latest follow-up in the medial patellofemoral compartment only. At the latest follow-up, the mean patellofemoral pain and functional score was comparable in both the groups. There was statistically no significant difference in the pain and functional score recorded at latest follow-up. These are the examples to show you the change in from the preoperative to the postoperative increase in the lateral patellar tilt in the knees with UKA. Similarly, decrease in the lateral patellar tilt with high tibial osteotomy. The progression of osteoarthritis is clearly seen in the medial patellofemoral compartment in the knees with UKA. To discuss, firstly, the average age of the knees in the UKA group was higher than the knees in the high tibial osteotomy group. Secondly, careful evaluation of the OA grade shows that the knees with the UK had a higher preoperative OA grade in the medial patellofemoral compartment to start with. And lastly, the mechanical benefits of HTO on the patellofemoral joint could have influenced the outcome. The reasons for the patellofemoral scores not showing any deterioration can be several. First, the progression of OA seen in the patellofemoral joint was not symptomatic. It may have been the result of normal aging only. Secondly, the mechanical benefits of UK and HTO on the patellofemoral joint could not have influenced the outcome, as overload of the patellofemoral joint from varus deformity could have been reduced by correction of the alignment achieved by the surgeries. The main limitation of the study is that it had a retrospective design. In addition, the design is relatively mid-term in nature, which prevents drawing any conclusions of long-term results. Thank you.
So you are in time. So what is this message in this study?
Sir, if you have done a literature review, there is a concern about the progression of osteoarthritis in the untreated compartments. There is a debate what surgery should be offered, whether a UKA or a HTO. So with this study, I would like to say that earlier studies have not compared the two procedures. They have spoken only about procedures of HTO or UKA giving progression of osteoarthritis. But here we have a comparison between the two procedures, showing that there is comparable results, and the progression, if occurs, is occurring only in the medial patellofemoral compartment in the UKA knees. And the grade of osteoarthritis in the patellofemoral compartment preoperatively has got no bearing on the functional outcomes eventually.
Well, if you do high tibial osteotomy, whatever the prospect of future conversion to total knee
Yes, so there is
replacement?
enough literature which doesn't show you any difficulty in surgery. Because in a high tibial osteotomy, if you are doing a medial opening with high tibial osteotomy, the results are much better than the earlier results of closed osteotomy on the lateral side. They cause the problem of total knee replacement conversions, but the newer techniques of medial opening with high tibial osteotomy are not very difficult to convert to TKR.
Dr. Sopti,
Yes,
where was this study done?
So this was done in Konkuk University in Korea,
So,
South Korea.
Korea.
yeah, are we sure this, a work done in Korea, I'm sure, a work done in Korea, can it be considered?
This work done in Korea,
Right.
in the perspective of Korea,
So, but again, it comes under Asian population. You have a lot of procedures now done in the US, which we are eventually following here. So it's a development of science.
This needs a long-term observation, isn't it?
So it's a minimum follow-up of 6 years.
This follow-up is 6 years?
Yes, sir.
Okay, so we will pass on to the next
Thank you.
person. We'll pass on to the next. Who is that? Jan Basa. Jan Basa, number 10. Jan Basa is here.
Yes, sir.
3 minutes presentation.
Good morning, respected chairman and my colleagues. Today my topic is management of proximal humerus fractures with percutaneous cable fixation. As you all know, this is the most widely used procedure. The proximal humerus fractures can be surgically managed by open reduction technique by various plating techniques and percutaneous cable fixation. The latter has more advantage as it has a biological fixation and no soft tissue dissection, and it preserves the vascularity and chance of less infection, and it aids early mobilization and minimal post-op complications. The only disadvantage with this is it is little less stable fixation compared with other platings. The aim of the study, this is to analyze the functional outcome of the proximal humerus fractures fixed with percutaneous cavities. The materials and methods we used, we have done this study, this is a prospective study we have done from June 2012 to November 2013 at Usmania Medical College, Hyderabad, and 20 cases were observed in our study. The inclusion criteria was the proximal humerus fractures classified by the NEERS 2 parts and 3 parts fractures were included, and the exclusion criteria is NEERS 4 part fracture and severe metaphyseal combination and non-compliant patients and mentally ill patients. The radiographic evaluation, the trauma series consists of the proximal humerus, AP and lateral Y view and axillary views are taken, and if at all displacement is more, then we take CT axials with 2 mm sections. The instrumentation, the simple instrumentation, the K-wires with 2.5 mm thickness and terminally threaded with 6 inches and 9 inches, and we use a K-wire cutter and a power drill. The procedure, in the procedure anesthesia, usually general anesthesia, sometimes regional nerve block. The position of the patient will be regular on the operative table. The image intensifier is used from the opposite side of the surgeon, and reduction techniques. In the reduction techniques, give a longitudinal traction in supine position, give a longitudinal traction, reduce the fracture and see it in the image intensifier, then check for the head offset and medial buttress, axial alignment and angulation and Gothic arch. The placement of the pins, 2 pins just above the deltoid insertion and 1 pin through the anterior cortex. If at all GT is fractured and displaced, then you have to add 2 more pins from the retrograde fashion. The pins are bent and cut so that they cannot be fall back, come back, or they go inside. And follow-up and physiotherapy. Every week exercises were be taken and evaluated for pin migration and the chance of union. Pendulum exercises were started after 3 weeks. Shoulder strengthening and resistance band exercises are started gradually after 6 weeks. The pin removal was done after 6 weeks. Complications we faced: pin loosening, pin migration and pin tract infection. The results were evaluated on the constant Morley shoulder outcome score. These are the cases. This is bilateral shoulder dislocation with an electric shock. This patient we reduced under general anesthesia and we fixed with percutaneous fixation. Case number 2, this is a female lady, 32-year-old female lady. She has a 2-part GT fracture. We fixed with K-wire fixation and got excellent result. Third case, this is surgical neck of humerus 2-part fracture again. We fixed with K-wire fixation and we got good results. Comparison with our study, we have done the comparison with Rush et al. Study. We got excellent to good 75% and fair to poor is 25%. In conclusion, proximal humerus fractures may have many different personalities, and treating surgeon must understand the fracture pattern, the quality of the bone and the other patient related factors. Percutaneous pinning is the best option for treatment of proximal humerus fractures in all fractures and in elderly age groups especially, except those in exclusion criteria we have mentioned. it gives less soft tissue dissection, less chance of infection, less hospital stay, early mobilization, and last but not the least, cost effective. Thank you.
Okay, Janbasa,
Yes.
isn't it?
Yes.
If I'm pronouncing correctly. Actually, these are the cases you have done by yourself or have taken from others?
No, sir. This is from myself.
Your cases?
Yes, sir.
You have done by yourself?
Yes, sir.
So how do you reduce? You have told that you will put traction.
Yes, sir.
So only traction and no counter traction, how will you do that?
Sir, I mentioned is we give counter traction and traction as we do it in a shoulder reduction, and after we'll keep in little abduction.
Now how do you give counter traction?
We'll give a counter traction by using sterile gown, sir.
Sterile gown,
Yes,
where?
through the axilla. Through the
Axilla, okay. So how do, you have told about the old cases, is it about 60, above 60, isn't it?
Yes, sir.
So in osteoporotic bone, how you fix with this KVAS?
Sir, as proximal humerus fractures, the cancerous part of the bone is more there. So we selected only the fractures which are not severely comminuted.
So you told 2 parts fracture with greater
Yes, sir.
tuberosity also you have
Yes, sir.
told.
First, we have to reduce the fracture in such a way that it should be very close to the fracture. Then we have to fix it with K-words.
In which case you have failed?
2 cases we have failed, sir. The thing which we did is we cut the pin at the skin level. We thought only 1 centimeter we keep it outside. We thought it is going to be stay there, but unfortunately it got migrated into the scapula. We have to undergo to theatre and artery.
Yeah.
Dr. Janbasa,
Sir.
have you ever tried to use any X-fix or a distractor or a...
No, sir.
This is being reported,
Because
almost
we do it
published
under
now.
general anesthesia, sir. That was sufficient to give a data addiction.
How do you take the lateral view X-ray on the, you told it is in supine position?
Yes, sir.
How do you take the lateral view?
Sir, we tilted the head end at 30 degrees, sir, and we put a pillow beneath the scapula, sir. So it's not exactly lateral, sir. Little oblique view we took it, sir.
So you get the lateral view.
Yes, sir.
Acha, your is finished. Next, is there anybody else? Number 12, number Janbasa is over. Anyone? You have got your poster here?
Yes, yes, sir.
We will have a discussion.
Loaded. I have
Huh?
uploaded.
Loaded, very good. What is your name? Number?
Dr. Raju Tukra.
Number?
Tukra.
Tadahar. 2. Number 2. Raju Tukral, please present. Yeah. Your topic is log plating. Okay.
Good morning, Chairperson and my colleagues. My topic is log plate of the implant, stable supracondylar periprosthetic femoral fracture by ORIF and MIS techniques. By background, main issue is the osteoporosis comminution and the bone loss, and hypothesis is the distal femoral locking plate provide the adequate angulation and rotational stability, thereby permitting the early mobility. Biological fixation may offset the problem of the delayed union. Aim of our study is to study the result of the surgical treatment of this fracture by the open reduction and internal fixation and biological fixation method to suggest an algorithm for the treatment of this difficult fracture. We divided the patient into 2 groups, group A and B. In group A, there were 17 patients where we did the ORIF plus bone grafting, and in group B, there were 14 patients where we did the closed reduction internal fixation by MIS technique. Exclusion, follow-up and assessment, clinico-radiological follow-up, 6-week interval and then 6 monthly. Outcome measures are the radiological union, time to union, scoring. We did the scoring by the Knee Society knee scoring and VAS scoring. Complications are the deformity, limb stiffness, and failure. In the case of the failure, we did the secondary additional procedure. These are our results at the 6 month KSS scoring in the group A. For the clinical was 56, and for group B it was 74, and functional knee society knee scoring was 51 in group A and 62 for group 2.
This is the last one.
Complication we found the in group A complication rate are high, and in group B complication rate was the less. Now conclusion: excellent result with the distal femoral log plate, permit the stable fixation and early mobilization, and biological plating possible in certain fracture pattern, and may decrease the need for the primary grafting. But fracture reduction is the key. Soft tissue preservation principle should follow, and understand the limitations. There may be the malunion in the case of the less inadequate reduction. Point to note is, or if of the comminuted fracture is associated with the longer time of the union, primary bone grafting is usually necessary, and precise surgical technique and the principles are the critical in the biological plating techniques to prevent the complication like the malunion. Thank you, sir.
So you have finished your, how many cases you have shown?
31.
31. All have been done by yourself?
Surgery was done by Dr. S.K.S. Maria. I am in the Dr. Maria's team, and
What
all the
a-
surgery is done by Dr. S.K.S. Maria.
What is the percentage of the periprosthetic fracture you get in your series? In your series of arthroplasty?
So less than 1%.
Pardon? Less
I
than?
didn't calculate it, but less than 1%.
Less than 1% you get. All have been treated identically by this method?
Also, we followed the two methods. One is the ORIF with bone grafting, and second one is the MIS technique.
MIS?
Yes, means
The minimally invasive.
Minimally invasive, no need of the bone grafting.
So what is your observation of steepness of the knee?
Sir, there is a less stiffness of the knee in the MIS technique, and there is no need of the bone grafting in the MIS technique. And all the complications we have seen is less in the minimum invasive techniques.
How are you doing it through the bone cement that has been inside the canal? How are you applying the screws in the bone cement?
The bone cement.
Some of the stems, some of the prosthetic stems, there are prosthetic stems there,
Yes, sir.
isn't it?
Yes, sir.
So how will you utilize this drill for that fixation?
You want to know how do you apply the screws?
Sir, in the MIS technique, sir.
Yeah, what technique you have done?
Yes, sir.
So did you get any difficulty?
Yes, at the time of the cement.
Breakage of the drill bits, all these things, have you got any
No,
difficulty?
sir. No, not breakage, but the little bit difficulty in the drilling.
Where?
In the distal part of the femur, sir.
What is the rate of infection?
Rate of infection is less in the MIS technique as compared to the means open reduction tunnel fixation with bone grafting. Sir, I have shown, sir.
If you take a longer time to handle all these things, then you will get chance of infection.
Yes, sir. Superficial infection was in group 1, group A, it was 2%, and in group B means it was 0%. MIS technique it was 0%, and in the open reduction tunnel fixation it was 2%.
Okay, thank you.
Okay, thank you. So is there anybody they have come? Anybody who has come with a poster? Anybody who has come with a poster? Huh? Anybody, please, anybody, any competitor who has come with a poster but not prepared the slides. There is an instruction from the IOA.
No. Poster dekhe do ni?
There is an instruction from the IOA office that if anybody has not come prepared with the PowerPoint, he should show his poster here. We will discuss.
Poster ready?
No.
Okay.
If there is no competitor coming, we have to wait here for 10 o'clock. Yes, that is the rule, because it is a gold medal competition. We'll wait for 10 o'clock and then we'll close it. Within 10 o'clock, if anybody comes, we'll entertain. Isn't it?
I think that should.
Yeah, we should wait.
Somebody may got information late or something.
May get information. Pardon? नहीं अगर हम लोग इसमें क्या करेंगे ना हम बता रहे हैं आपको इसमें हम लोग सेशन स्टार्टेड एट 9:05 और 9:10 लिखिए ना साथ ही साथ काम खत्म करो हम 9:05 ना 9:10 9:05
First speaker is Dr. Ashwini Sadana. He'll be discussing with the emerging trends in the management of inflammatory polyarthralgias. Please, Dr. Sadana.
Good morning, chairpersons. Good morning, dear friends. The topic assigned to me is emerging trends in the management of inflammatory polyarthralgias. Now, we all know rheumatoid arthritis is a chronic multi-system disease of unknown cause. The main feature is a persistent inflammatory synovitis involving peripheral joints in symmetric distribution. The etiology to a large extent is unknown, though certain genetic predispositions have been blamed and may be a manifestation of a response to infection by mycoplasma or EBV. Now, the pathology includes the hyperplasia and hypertrophy of synovial cells, production of interleukin 1, interleukin 6, TNF alpha, and this is important because when we talk about the biologicals, this will come. Interleukin 1, interleukin 6, TNF alpha, and PGE2. The diagnosis. Now, the diagnosis of rheumatoid arthritis, we have got this criteria. Any four of the following must be present to allow a diagnosis of RA. Now, morning stiffness more than 1 hour, 3 or more joints involved, arthritis of hand joints, symmetric arthritis present for or more than 6 weeks, rheumatoid nodules over bony prominences on external surface, rheumatoid factor positive in more than 5% of our subjects, and radiographic changes. Now, the extra-articular manifestations of rheumatoid arthritis include pericarditis and interstitial lung disease, Peltier syndrome, etc., etc. And this illustration shows the involvement of joints. So, the shoulder joint, wrist joint, knuckles, and middle joints of the fingers, knees, ankles, middle joints of toes, and balls of feet. Now, don't forget the cervical spine. Instability of the cervical spine can lead to impingement of the spinal cord. Thoracolumbar, sacroiliac, and distal interval joints of the hand are not involved in RA. This is one of the patients with ulnar deviation, MCP swelling, and a left wrist swelling. And this is an illustration of a PIP swelling. This is an illustration of a Botnia's and a swan neck deformity. I'm not going into details of these. Now, the investigations we use in RA. The one common is a rheumatoid factor, which is positive in about 80% of cases, but it is also present in about 5% of normal individuals. Now, when it appears in patients with arthritic pain on both sides of the body, it is a strong indicator of RA. The higher the ESR, the greater is the inflammation, help determine how active the condition is. The C-reactive proteins, the high level of C-reactive protein CRP are also indicators of active inflammation. The anti-CCP antibody test, the presence of antibodies to cyclic citrullinated peptide CCP, can identify RF years before symptoms develop. Test for anemia, normocytic, normochromic. The rheumatoid factor, we know that it has got a prognostic value. Patients with high titer of RF in general tend to have poor prognosis, more extra-articular manifestations. Anti-CCP is immunoglobulin against synovial membrane peptides damaged by inflammation. It has got a sensitivity of 65% and a specificity of 95%. It's got a both diagnostic and prognostic value, and it is a very important predictive of erosive disease severity, radiologic progression, and a poor functional outcome. Now, the acute phase reactants, they can be positive acute phase reactants, which are raised, and negative acute phase reactants, which go down. Now, the moderate elevation of fibrinogen, ESR, and marked elevation of C-reactive protein. Now, C-reactive protein correlates with the disease activity and radiologic progression. one of the most responsive acute phase reactants, can be elevated in many RA-related diseases. ESR influenced by non-acute phase response factors and can be elevated in many non-RA-related diseases. The radiograph features are periarticular osteopenia, uniform symmetric joint space narrowing, marginal subchondral erosions, joint subluxations, joint destructions and collapse. Now, ultrasound detects early soft tissue lesions. That's a very important part. And the MRI has got the greatest sensitivity to detect synovitis and marrow changes. Now, this is an illustration of the X-ray changes, which showing erosions, early erosions in rheumatoid arthritis. Now, imaging techniques we use are X-rays, DEXA scan, and ultrasound. Special ultrasound techniques called power Doppler ultrasonography or quantitative ultrasound may be helpful in RA. MRI, specially designed MRI equipment called extremity MRI may be able to detect bone erosion in the hands of RA patients where X-rays cannot. Now, this is what has come from the ULAC, London. The power Doppler ultrasound is useful in determining the tumor remission. Now, this is a study which conducted in 109 RA patients on TNF alpha, and this shows that absence of PD signals guarantee arrest of radiographic progression, whereas patients with PD signals are at risk of progression despite treatment with TNF alpha blockers. The risk increases with higher PD grades. PDUS, the power Doppler ultrasound, is useful in evaluating patients considered to be in remission. Monitoring progression, we have been using the DAS score, the disease activity score, DAS28. It is widely used indicator of RA disease activity and its response to treatment. The joints included in this DAS28 are PIP, MCP, wrists, elbows, shoulders, and knees. Now, when looking at these joints, both the number of joints with tenderness upon touching, that is 1028, and swelling, that is SW28, are counted. In addition, the ESR is measured. A score less than 3.2 means the patient is inactive. The 3.2 to 5.1 means moderately active disease, and more than 5.1 means active disease. Now, this I'm not going to detail, but this is a very important 2010 ACR ULAR classification of this. Now, the goals of the therapy. The goals of the therapy are to alleviate pain, preservation of function, control the disease activity, maximize the quality of life, and slow the regression rate of the joint damage. Now, these include the physical therapies, the diet, the pharmacological therapies, the NSAIDs, glucocorticoids, DMARDs, biologics, surgical treatment, and future trends. Now, the important part in the physical therapies is splinting can prevent unwanted joint movements. Exercise is directed to maintain muscle strength and joint mobility. Some studies now suggest that omega-3 fatty acids may reduce the rheumatoid arthritis inflammation. And since we are all knowing, there can be non-selective COX inhibitors and selective COX inhibitors. Now, etoricoxib 90 mg OD has the highest selectivity ratio for inhibition of COX-2 and a superior efficacy compared with 5 mg naproxen BD over 12 weeks. Now, this is an important one. Smokers have no window of opportunity. This is data from Barfoot. With patients with early diagnosis disease, less than 3 months show significant improvement each month when treated, but smokers don't show this trend. So, smokers are less likely to respond to early treatment of RA. Risk factors, and then one of the major misconception is that these GI perforation is now this is very clear now that GI perforation is rare and increases with age, steroids, and especially the history of diverticulitis. But NSAIDs, which we are blaming, they impose only a very minor risk for GI bleeds. Now, early addition of low dose, now this is another camera 2 study. This shows that early addition of low dose prednisone does help. Low dose prednisone at start of the treatment leads to better control and no increase in toxicity. Now, glucocorticoids, we all know, I'm not going to detail here, but DMARDs, the stabilize joint function as early as possible, better outcome, greater awareness of NSAID toxicity, and DMARDs do slow the disease progression. Now, we know there are commonly used DMARDs are methotrexate, sulfasalazine, chloroquine, hydroxychloroquine, leflunomide, cyclosporine, and azathioprine. Now, there are advantages, but now the trend is for combination DMARD therapy, the methotrexate plus sulfasalazine, methotrexate plus hydroxychloroquine, methotrexate plus cyclosporine, or methotrexate plus leflunomide. The important part is methotrexate, the excellent safety and improved efficacy of methotrexate alone also. So, who should we put on DMARDs? Those who have failed to respond to, who should we put on the combination of DMARDs? Those who fail to respond to one DMARD or the partial response, when to change if response is not adequate, toxicity develops. Now, how to combine two drugs? There can be a step up approach or a step down approach. Now, there are many adverse effects of these DMARDs. Sulfasalazine inhibits the inhibition of the in vitro beta cell proliferation. Gold compounds also are being used. Now, biologic pathways. Now, this we know that the nomenclature is based upon the antibodies, whether Zimab, chimeric antibody, Zumab, humanized antibody, Zumab is human antibody, and Sept is fusion protein. Now, these are the newer drugs that reduce the RNA inflammation in more highly targeted manner than the DMARDs. They are made through biotechnology and target very specific proteins or cells that are involved in the inflammatory process. The currently available biotherapies for RA must either be injected into the skin, that is etanercept, adalimumab, or infused, that is infliximab or abatacept. Then we'll just talk about the interleukin-1 antagonist. Anakinra is a recombinant human interleukin-1 receptor antagonist, and do not use in combination with TNF-alpha. That's important. Then beta cell depletion therapy, targeting beta lymphocytes in these patients has opened a new therapeutic window. Now, adverse effects of biologics is important. Infusion-related serious infections, TB, activation of latent TB is important here. The surgical treatment is also there, but this is beyond the. Thank you.
Thank you very much. Any questions? Yes, please.
Useful marker.
Sir.
Very useful marker for detection whether the disease has burnt out or not.
So we were been using ESR and CRP, but now the trend is coming for the PDUS, which is being now in the West outlined as the benchmark for the progression of disease. And earlier changes, though we detect in MR, but PDUS is being now advocated by the American Rheumatoid Association as the benchmark for deciding the progression and the effect of treatment. Thank you.
Yes.
What is the role of chemical synovectomy?
So chemical synovectomy, they are claiming, but the long-term results are still in limbo. I'd like to add one word, though we are talking a lot of chemicals, lot of drugs, but now the studies in our hospitals we're doing in medical college, that yoga, meditation, these are having very profound effects in rheumatology patients, in rheumatoid arthritis patients, established cases, and we have done studies where the markers, the ESR, the CRP have shown significant downtrend by this yoga alone. We maybe we're trying to publish those studies, and whenever the data comes, we'll share with you. Thank you.
Yes.
When should we advise to do anti-CCP antibodies?
So anti-CCP antibody is basically the initial marker. So it is the most specific marker. Sensitivity is not up to that mark, but specificity is great. And ideally it should be the first investigation if you are suspecting polyarthralgia.
So suppose the patient is RA positive, should we advise anti-CCP antibody?
So RA to me will still keep you in a limbo. You will not be able to decide whether you're dealing with rheumatoid arthritis or not. Anti-CCP, you will be in a better position
so
to.
It should be included in the initial,
It should be included. To me, it should be included. But the cost factor is one thing. That's the cost factor is the problem.
The second question is, you are combining methotrexate with everything,
Yeah.
Suppose the patient does not tolerate methotrexate, then what to combine?
So as far as the data study shows, methotrexate is one of the most safest of these DMARDs. Methotrexate to date is one of the safest of DMARDs, and it's, the incidence of sensitivity to methotrexate alone is pretty low. But even if then we have got other combinations, sulfasalazine and hydroxychloroquine is possible.
Without methotrexate?
Yes, without methotrexate.
Even we can combine 3, 4.
Yeah, we can. So that studies are still coming up. How many drugs to start with, 2 or 3? That's a lot of controversy still there.
Okay.
Thank you.
Last question is, sir, last question. What is the role of corticosteroid in the initial stage? Because there is some confusion between us and the physicians,
So there is corticosteroids have got two things. Number one, low dose pulse therapy, initial stage, low dose prednisone, and now they are coming up with high dose corticosteroids in acute flare-ups. There is study going on, and they with very good result, but still that is under review.
Combine initially with the DMRDs.
You can. Initial first day you can. Okay, thank you, sir.
Okay, can you, my question and last question.
Yeah.
Can you tell us the duration of the treatment?
Yeah.
How many years it should be continued, when it should be reduced or stopped?
So the claim by the rheumatologist is that the biologics need to be taken lifelong at times. But again, there is a lot of controversy in biologics also, because they have got major side effects and they need to be monitored. And I think the problem in this country is we don't have rheumatologists and orthopedicians are not busy from the fixations. So this group of patients, which is a pretty large chunk of patients with polyarthralgias, spondyloarthropathies, they are neglected.
Can we reduce the DMRD? So patient is comfortable, ESR comes down. Can we still reduce the DMRD?
Sir, it depends upon the DMARD you're using. There are different ideas for different DMARD, different combination. So it is specifically for the DMARDs.
No, suppose using 3 drugs, can we reduce to 2 drugs?
Yeah, yes, you can, and this is advocated also. After say 6 months to 8 months, you should reduce from 3 to 2 drugs.
Okay, thank you very much.
Thank you, sir. Thank you.
Now the next speaker comes Dr. S. Vora. He will be discussing on seronegative spondyloarthropathies.
Good morning, chairpersons and friends. I've been asked to speak on seronegative spondyloarthropathies. This is a group of inflammatory disorders which affect joint, spine and periarticular structures along with some extra-articular manifestations, and most of them are positive for HLA-B27 as well as they are essentially negative for the rheumatoid factor. Now the conditions which are included in this group include ankylosing spondylitis, which has inflammation of joints, reactive arthritis, which is normally in response to some infection, also referred as Ritter syndrome. Psoriatic arthritis is associated with a skin condition called psoriasis, and enteroarthropathic is associated with inflammatory bowel disease, including diseases like Crohn's disease and ulcerative colitis. And undifferentiated spondyloarthropathy, which does not fit into any of the above, is labeled as undifferentiated. Now, why are these diseases clubbed together? Because they have certain features in common. First, foremost being the HLA-B27 positive for all of them, enthesitis, both juxtaarticular as well as extra-articular, spondylitis and sacroiliitis, peripheral arthritis, which generally it is asymmetrical involvement, extra-articular manifestation in the form of involvement of eye and genitourinary tract, and they are essentially, their sero status is negative for rheumatoid factor as well as anti-nuclear antibodies. The patients suffering from these diseases, the association with the percentage Y with B27 is like Angspont, about 90% are positive for HLA-B27, about 70% for reactive arthritis, enteropathic arthritis, about 50% of them are positive, and psoriatic arthritis, about 35%. Now coming to ankylosing spondylitis, hurriedly, about 90%, as I said, are positive for B27. It's a chronic inflammatory of sacroiliac joints and spine. Bilateral sacroiliitis is the hallmark of this disease. The peak onset is in the late adolescence. Males are more commonly involved. It's more common in whites. The diagnostic challenges, one needs to take a careful, detailed history and a clinical examination. The back pain is quite specific in ankylosing spondylitis. It involves the lower back as well as the buttock. It's a nocturnal pain. A very specific thing about it that the pain relieves with exercise and it does not relieve with rest. Similarly, we need to see the evaluation of the joints. There's a test called Schobert test to see the limitation of forward flexion and the reduced chest expansion. In these patients, the respiration becomes diaphragmatic. The Schobert test I was talking, we draw an imaginary line from the iliac crest, 5 cm below and 10 cm above. Normally, when a patient is subject to forward flexion, it is about 15 cm. It should be plus 5 cm. If it is less than 5, we label it as a restriction of movements. Similarly, the clinical manifestations, the lumbar lordosis gradually decreases and the thoracic kyphosis gradually increases. Cervical ankylosis is also seen pretty common in about 75% patients, especially in those who have a very early onset. Enthesitis is seen at the sites like ischial tuberosities, greater trochanter, anterospheric spine, and iliac crest. So this is how the posture goes. Some of the extraskeletal manifestations include fatigue loss, weight loss, grade low grade fever. The eye involvement is pretty common. Rather, this is the most common extraskeletal manifestation of ankylosing spondylitis. And here the patient develops pain, photophobia, blurring of vision. And the cardiac, we have aortitis, will lead to fibrosis. We also have conduction defect. Pulmonary fibrosis which leads to restriction of respiration movements, amyloidosis, and some neurologic like cardiac venous syndrome and C1, C2 subluxation. The lab evaluation, as I said, most of them are positive for B27. We find increased ESR and C-reactive protein. Anemia is typically normochromic, normocytic, and they are essentially negative for rheumatoid factor and anti-nuclear antibodies. Regarding X-rays, we see narrowing of the SI joints, and in the later stage we might see fusion also, and in some of cases we find what is called pseudo widening when subchondral bone resorption starts. Bamboo spine, as typically described, the ossification of the anterior spinal ligament as well as fusion of the apophyseal joints of the spine. We also see fairly good syndesmophytes and the squaring of the lumbar vertebra, especially of its anterior concavity. The reactive bone sclerosis is also labeled as a Romanus lesion, where the superior and inferior margin give rise to bone sclerosis in the later stage. We see osteopenia and straightening of the cervical spine. Hip and shoulder are rarely involved. So these are some of the X-rays, how it looks like the bamboo spine and the SI joint involvement. Power Doppler ultrasound has also got a good role to play, especially in the early stages, and also to see the response of our therapy when we put the patient on the drugs. MRI and CT scan detect those early sacroiliacal erosion and enthesitis which are not visible on the X-rays. If we compare ankylosing spondylitis with rheumatoid arthritis, both of them have synovial inflammation which leads to destruction of articular cartilage and ankylosis. But just to differentiate few points, ANK is more common in males, whereas rheumatoid find more in females. We have essentially absent rheumatoid nodules in ankylosing spondylitis, and they are absent for the the rheumatoid factor. We also see pre-spinal calcification more in ankylosing spondylitis. Regarding treatment, the physiotherapy and NSAID is the mainstay of the treatment. We educate the patient to lie supine or prone mode to prevent flexion contractures. Extension exercises advocated by all of us. Swimming is a very good mode of physiotherapy for these patients. We also advise them for deep breathing exercises and cessation of smoking. Regarding NSAID, earlier we used to do phenylbutazone, later it was joined by indomethacin, but fairly good response is also received by naproxen, piroxicam, and the latest being meloxicam. Steroids have a fairly good role, and even the topical drops are used for the extraskeletal manifestation like uveitis. DMARD, sulfasalazine, and methotrexate, they help also to affect the disease process as well as improve the movements of the joints. Latest in this list is the tumor necrosis factor alpha blockers, which include etanercept, infliximab, and adalimumab. National Institute of Health and Clinical Excellence has recommended the use of etanercept. Infliximab in combination with is recommended for the dose tolerant to etanercept. Etanercept or infliximab should be used under a specialist supervision. A special study has been conducted for ankylosing spondylitis, the role of etanercept in that. With the latest update in this, a very essential one to know for all of us. Then as late as October 2013, the FDA approved the tumor necrosis factor inhibitor called sertolizumab pegol. It was based on the approval, the study of phase 3 multicenter randomized study, which has studied the evaluation, the efficacy and safety of the drug. The surgical indications are when we need to do vertebral osteotomy, especially for the cervical spine or the or the upper thoracic spine, where there is a complete fusion, flexor stabilization, and joint replacement in the later cases. This is especially for when the hip joint is involved. Coming to reactive arthritis, also referred as Rita syndrome, the triad include conjunctivitis, arthritis, and uveitis. Again, more common in males. The responsive organisms are chlamydia, campylobacter, yersinia, also salmonella and shigella. Again, more common in whites. Clinical measures sometimes start 2 to 4 weeks after the initiation of the infective event of genitourinary tract or GIT tract. Again, asymmetrical, lower extremity is more involved as compared to upper one, and in lower limb we find knees and ankles involved. Hip is rarely involved, as I'm saying again. Upper limb, wrist, elbows, and small joints are bad. Also, we talk of sausage digit. It is the whole of the finger or the toe is swollen with dust-like blue discoloration, and they are very painful. Enthesopathies and sacroiliitis, we all know. This is how the sausage toes look like. The other extra articular manifestations, the eye I have already talked. This genitourinary balanitis ulcerata, they are shallow ulcers on the glans penis, and the skin, and we see keratoblenerarica, they are hypertrophic ulcers on soles. Cardiac effects we already talked, and the general symptoms. This is how the keratoderma blenerogica look like, and this is how succinate balanitis looks like. Again, left-sided synovial fluid shows inflammatory changes with increased ANSR and negative rheumatoid factor. Anemia is again synovial fluid. We see turbid, poor viscosity, and high leukocyte count with increased proteins. X-rays, we see the lower yield, what is called as erosion and periosteal changes at the insertion of plantar fascia and Achilles tendon. Ischial tuberosity then greater to enter the other sides to see asymmetric sacroiliac joint is always seen here with syndesmoid, and pencil and cup deformity typically described when there is osteolysis of phalanges as well as metacarpals. So this is the symptomatic. Coming to psoriatic arthritis, the epidemiology part, about 5 to 7% of patients with psoriasis develop psoriatic arthritis. 0.1% of the population affected. Here the male-female ratio is almost equal and the onset is a little later age. A word about psoriatic arthritis associated with HIV, it is little different. Here the foot and ankle involvement is the most common and very severe. The treatment is almost same as psoriatic except that we avoid using steroids and methotrexate in this. The skin and nails, we coming to extra article again, the psoriatic skin lesions show erythema silvery scales. Auspit sign is when you generally scrape the lesions, a pinpoint bleeding is seen, and we also see the nail pitting. Coming to the arthritic manifestations, the larger joints are involved. Again, it is asymmetric, and there is stiffness of spine, encephalopathy, and sacroiliitis. Pencil and cup deformity on X-ray I have already described. Asymmetric lesion, if sacroiliit later on lead to fusion, we see fluffy periosteal. Treatment again physiotherapy, but it should not be overdone because at times it leads to exacerbation. NSAIDs, we all know steroids have a limited role, but we also use methotrexate and tuber necrosis factor inhibitors in this also. And the enteropathic enterocolitis, as I said, associated with conditions of the intestine like ulcerative colitis and Crohn's. Bacterial etiology is there, and males are again more commonly involved. And peripheral arthritis occur in 10 to 20%. Again, there is asymmetric joint involvement and sacroiliitis is seen. One important thing to mention is that peripheral arthritis subsides with the remission of bowel disease, which one we need to keep in mind. Extra-articular manifestations include like erythema nodosa in Crohn's and pyoderma and gangrenosa in ulcerative colitis. Okay. So these are some of the pictures how it looks, the extra manifestation look like. So we need to take a detailed history and a careful clinical examination, and then so that we can clean the diagnosis. And this is how we, on the basis of the epidemiological features, the involvement of joint as well as the extra-articular manifestations, we come to regarding prognosis. Here also we see spontaneous remissions and exacerbation. Disease activity generally persists for many decades. The factors which indicate the poor prognosis in spondyloarthritis are when the hip is involved, when there is a dactylitis, or if the age of onset is very young, or is ESI greater than 30. To conclude, now this group, this concept is well accepted of grouping it separately. We recognize the varied article and peri-article manifestations which improve to currently, which normally the diagnosis is delayed. MRI and ultrasound have got a good role in early detection of the disease. Basically, we should address the association of disease-modifying agent and their role in slowing of bony ankylosis. Also, one should elucidate the possible infectious etiology so that we can empower a more causative therapy. With the advent of these biological evidence, prompt recognition of these intertraders has become a critically important goal. Thank you so much.
Any question? Yes, please.
Sir.
When you do the vertebral osteotomy,
Sir.
in the kyphosis of the enclosing spondylitis, what is the indication?
When there is complete fusion and we have started having the compressive symptoms, then it is required. Otherwise, we do not do just for the sake of deformity. When the deformity has developed that much that it has started giving neurological involvement or compression, we need to go to decompress the neurological part. Thus, an osteotomy is required.
I am only asking for the vertebral osteotomy,
yes,
not
sir.
for decompression.
Okay, you will discuss later on. No, let him ask, please. After the session, you can discuss in detail.
Again, when to use steroids and when to use methotrexate in ankylosing spondylitis?
Ankylosing spondylitis, once diagnosed, methotrexate should be started from day one.
Immediately?
Yes.
Suppose we get response with NSAIDs, then why to use steroids?
NSAIDs are always joined with methotrexate, but methotrexate is supposed to be also like what is called a curative treatment. NSAIDs are always the mainstay of treatment with physiotherapy.
Okay. Yes, you please.
Sir, in what doses these TNF inhibitor etanercept are given, and in which form they are given, and for how long they are given?
Well, the TNF inhibitors right now, they are not very much used in our part of the state. They have already come in big, so I have no experience of using them right away.
And sir, this is about the TNF, these are alpha inhibitors. And in pathogenesis, as it is said, TNF beta lead to the fusion, whereas TNF alpha is responsible for inflammation.
Yeah.
So sir, TNF for beta, is there anything else in literature?
No, not at all.
Okay. Your basic lecture was on seronegative.
That's right.
And everything is present in seropositive also. So how you can say this is seronegative? Because problem arises when you get all the tests in the early stage. I'm talking that all tests are normal and still patient is having the problem. That's what you say is seronegative.
That's right.
So how you diagnose in the early stage, because no test is positive, purely on the clinical or any other?
Basically, it is clinical only, but of course we have to combine with the investigation part also.
No, but investigation in seronegative, most of the investigations are negative.
No,
And
but
it is seronegative.
HLA B27 will be positive, no, sir?
HLA?
B27.
So you mean HLA B27 should be done in clinical
Yes,
when you doubt.
whenever we survive in this set of symptoms and signs what we have discussed.
Okay, that is positive in 70-80% cases.
90%.
90%. Any other?
The literature says 90%.
Okay, thank you very much.
Thank you, sir.
Now the next speaker is Dr. Amit Agrawal. He will discuss you on the recent advances in managing hyperuricemia. Dr. Amit Agrawal. Please stick to the time.
Good morning, everybody. The topic of my presentation is recent advances in managing hyperuricemia. Now, as we all know, what is gout? It's basically a disorder of urate metabolism in which we have hyperuricemia, whereas we have deposition of monosodium urate crystals in joints and soft tissues. Now, it's a heterogeneous group of diseases which results from tissue deposition of monosodium urate crystals or uric acid in supersaturated extracellular fluids. Now, what is gouty arthritis? It is a recurrent attack of articular and periarticular inflammation. Tophi, it's accumulation of articular, osseous, soft tissue and cartilaginous deposits, and one of its manifestation is also urolithiasis. This cascade shows how urate metabolism affects hyperuricemia, and we have silent tissue deposition, one of which features is gout, another is renal manifestation, and there are also associated cardiovascular events and mortality. This diagram shows about the uric acid metabolism, in which how either uric acid hyposecretion or uric acid overproduction leads to gout. Now, acute gouty arthritis, the first attack usually starts at the age of 40 to 50 years. The onset is before the age of 25, and classically the first attack is monoarticular and involves the first metatarsophalangeal joint. The epidemiology, the peak onset is 40 to 50 years. In women, peak onset is postmenopausal. Prevalence is influenced by hormonal geographic conditions. It's seen that it's more common in hypertensive patients with renal transplant, and it's often seen that gout is more common in spring, especially summer. Now, coming to the clinical presentation, there is a rapid onset of pain, erythema, warmth and inflammation. In night, patient usually wakes up from sleep. It's mostly monoarticular. There is fever, leukocytosis, and it lasts for 3 to 14 days if untreated. The diagnosis of gout is mainly by the aspiration of synovial fluid or tophi, which shows particular character. Now, coming to the treatment of gout, it terminates acute flare-ups as rapidly as possible. To protect against further attacks, prophylactic treatment in the intercritical period, and to correct hyperuricemia. Now, this is the management of gout, in which we first resolve the acute flare, then we initiate the urate lowering therapy, then we maintain the treatment to control serum uric acid. Now, what are the challenges in the gout management? First is the failure to monitor and adequately lower the uric acid level. Second, the failure to use prophylactic therapy when starting hypouricemia medication, or stopping or starting the hypouricemia therapy during an acute attack of gout. We are usually faced with these challenges. Now, what to recommend to patients? First is the dietary recommendation. We tell them to avoid dietary triggers, as I will tell you later on, control hypertension, and to optimize medical care. Now, coming to the treatment of gout, Most acute attacks of gout, they can be managed with colchicine, NSAIDs and corticosteroids. However, many patients have elevated uric acids that can eventually lead to frequent or refractory attacks, for which I will tell you. Now, anti-inflammatory therapy with colchicine or NSAID is recommended during the first few months of the maintenance treatment, which may be required for 12 months. In patients who experience frequent attacks of gout, maintenance treatment with urate lowering agent is necessary to prevent adequate prevention of further attacks. Now, allopurinol. Now, this has been the age-long backbone of the gout treatment, and it's a pure xanthine oxidase inhibitor. The starting dose is 50 to 100 mg daily, and some studies have suggested that only 21% of patients on 300 mg achieve urate level of less than 6. So this is the biggest disadvantage of allopurinol. Allopurinol functions as both as a substrate as well as inhibitor of the xanthine oxidase. However, it inhibits other enzymes in the purine and pyrimidine pathway. It's not tolerated by 5% of patients and has limited efficacy at a once daily oral dose of 300 mg. Now, the few more limitations are the rash, some allergies, and hypersensitivities. Other uricosuric agents available in the market are probenecid, benzbromarone, losartan, fenofibrate, atorvastatin, which have their own limitations, like they can trigger urolithiasis. They can also lead to more drug sensitivities. Now, these are the few limitations of the existing urate lowering agents. Now, the pitfalls with available anti-gout medication is their use in renal or hepatic function when they are deranged. Then their drug interaction, target serum urate levels not always achieved. They have potential fatal hypersensitivity syndromes. There is risk of nephrolithiasis, and there may be multiple daily dosing required for the control of gout. Now, coming to the advanced treatment for the refractory gout, which includes allopurinol intolerance, chronic kidney disease, abundant tophi, heart failure, hypertension, diabetics, advanced age, and multiple potential drug interactions. Now, the major breakthrough to overcome all these things came the febuxostat, which is now being considered as the gold standard for the management of gout.